Good eve- Yeah. Good evening, friends, respected seniors, and all the colleagues of CCI, the family of CCI. So I welcome everyone for this exciting webinar on allergic bronchopulmonary aspergillosis. So before I start off on the topic per se, I should first applaud the entire CCI core committee, the CCI team, the initiation by Dr. N.H. Krishna for this continuing academic webinars. Today I was discussing with Dr. Vijay, my dear friend, and it's very happy to note that we have now crossed 4 years of consecutive weekly every Thursday webinar on I can say every possible aspect of pulmonology, and without breaking for any 1 week. I think that is something which has not been possible by any association. So that is the dedication of CCI in disseminating academics. Also, a special thanks to the webinar core committee, which is headed by Dr. Vijay, Dr. Atri, Dr. Kirat, and Dr. Shivani. So all of them have been working very hard. So thanks once again to everybody. So today, to discuss on this very important topic of ABPA, we have 4 very experienced pulmonologists here. All of them are very close friends, associates and seniors of mine, and one radiologist who has exquisite interest in thoracic radiology. I'll be introducing each one of them in person. So, but before we go on to introduction, so for those who have logged in, what is so important about this disease? So does it warrant a webinar? So that is something which we all have to know. So ABPA, a disease, a decade ago was thought that it is not existent or it is not very important for most of us. But in the last decade, I think pulmonologists across the country, across the globe have realized that ABPA is something which we cannot afford to miss, especially when we're dealing with patients of severe asthma, when we're dealing with patients of bronchiectasis, so on and so forth. It's a disease which is very prevalent in India. It's a disease where India has shown the path in research and has given the global guidelines on how to manage. And coming to the impact on the person, so at least in 2 distinct scenarios, one is uncontrolled asthma and bronchiectasis. I think this is something which we should never forget. It is one of the few diseases where we have a cause of bronchiectasis which can be stopped or prevented. It is considered to be one of the only few preventable causes of bronchiectasis. So I can keep talking about the importance of ABPA, but then I will stop because we'll be discussing all these aspects also. So this is a disease which every pulmonologist should be aware. The in-depth about diagnosis, screening, treatment, management, and so on and so forth. So all of these we will be discussing. And with this brief introduction on ABPA, I will also now introduce my panelists for today's webinar. So certain housekeeping statements and how this webinar would flow. We have 1.5 hours time, of which I've taken 5 minutes already. So the first half an hour will be 2 lectures. One on the diagnosis and screening of ABPA, and second one would be on the therapy part of ABPA. Following which we would have complete 45 minutes discussion, panel discussion, wherein we will discuss the practical aspects of diagnosing and managing ABPA, and we will also be addressing the audience questions. So here I would request all those who have logged in to actively participate by typing as many questions as possible which come to your mind. There is no question which is wrong, so do not feel that this is a naive question. So we would appreciate if more questions come in. Correct? So now coming to the panelists, so I will start off by introducing Dr. Gayathri Madam. So Gayathri Madam, I was lucky to have met her in person last month at Chennai Apollo. So, Madam is a senior consultant, a coordinator, a Department of Respiratory Medicine at Apollo Hospitals, Chennai. So, welcome, Madam. And Madam will be giving the first talk on screening and diagnosis of ABPA. Then I would take the opportunity to also introduce Dr. Abhishek Tandon, whom I came to know is the reason that we are doing this webinar today. So the interest of Dr. Abhishek has what made this webinar finally fruitful. So thank you so much, Dr. Abhishek. So he's an associate consultant in the Department of Pulmonology at Medanta, Lucknow. He's a young, dynamic, and very active, very committed pulmonologist, I should say. Then coming to Dr. Mahavir Modi sir, my very good friend from Pune. He heads the department at Ruby Hall Hospitals, Pune. I have had the occasion of meeting, co-chairing, talking on the same platform. And in fact, Dr. Modi had, I will call him Dr. Modi. Yesterday itself, he has given an amazing talk on severe asthma. Am I correct? To almost 1,600 pulmonologists across the country. So we're very lucky to have you talk on AB to share your insights on ABPA. Then we have Dr. Mir Faisal, again my good friend from Kashmir. So we have representation from the north to the south. So from Kashmir to Tamil Nadu, we have representation. Dr. Mir Faisal is the director and head of pulmonology at the Orzo Medical Clinics in Srinagar, Kashmir. So we're very happy to have you, sir. And finally, Dr. Nikhil Gupta, who definitely adds value to our webinar. He is a radiologist by profession, but a thoracic radiologist by passion. Am I correct? So Dr. Nikhil also, I'm happy to share that he has also done his degree from PGI Chandigarh and currently practicing as a consultant at SPS Hospitals, Ludhiana. So there we are. So we have all the five panelists with us on board. So with this, I will request Dr. Gayathri Madam to first deliver the talk on screening and diagnosing ABPA. For the next 10 to 15 minutes, we'll listen and learn from Madam. Over to you, Madam.
Good evening, everyone. At the outset, I'd like to thank the CCI for giving me this opportunity to give this talk on ABPA, the screening and diagnosis. And I also thank the moderator of today's session, Dr. Nagarjuna, for his kind words of introduction. Without further ado, we will start the discussion on ABPA, screening and diagnosis. ABPA is an inflammatory disease exacerbations, and the revised guidelines mark a value of more than 500 as a cutoff to diagnose ABP. In India, the incidence is at 1.4 million cases. You need to have a high degree of suspicion for ABPA among asthmatics, especially because the early diagnosis and appropriate treatment can delay or even prevent the onset of bronchiectasis. So bronchiectasis, if untreated, will lead on to progressive pulmonary fibrosis and end-stage lung disease. So all of us are quite familiar with the earlier ISHAM guidelines, which came out in 2013, which really focused on the immediate cutaneous hypersensitivity to Aspergillus fumigatus, the specific IgE levels more than 0.35, and with specific note, the serum total IgE level more than 1000. And these were revised subsequently with the new revised ISHAM working clinical practice guidelines, which came out in 2024, which had doctors all from all over the world and as well as India and as well as our panelists were involved in this heartbreaking guideline on the revised guidelines for treatment of ABPA. So what was different? The ABPA earlier thought was only due to Aspergillus fumigatus, but now has been extended to the Aspergillus of other species also. And when it is caused by fungi other than Aspergillus, it has been called as ABPM. And a number of fungi have been implicated in the causative of the ABPM. And all the asthmatics, especially those who seek care in tertiary care centers and those who have difficult to treat asthma need to be tested for sensitization to aspergillus fumigatus. And in children, it is only those who have difficult to treat asthma who need to be tested for sensitization to aspergillus fumigatus sensitization. So the sensitization is checked by the Ig immune assay with a cutoff more than 0.35. It's the most widely used test to diagnose aspergillus sensitization, and it is the preferred screening tool. The various immunological tests include the aspergillus specific IgE and IgG levels, the serum total IgE, and the peripheral blood eosinophilia. The serum total IgE level is a very non-specific marker of the immunological activity, and there's a lot of differential diagnosis on why it could also be elevated other than ABPA. And the serum total IgE values will decrease during treatment, and this last recorded value is something of clinical importance, and it is called the new baseline. Any significant increase of more than 50% over this new baseline is used to diagnose exacerbations, and the revised guidelines mark a value of more than 500 as a cutoff to diagnose ABPA. The earlier cutoff was 1000, and with this lower cutoff, it offers a higher sensitivity. There are various immune assay and immune precipitation tests available, and these tests have various cutoffs in almost each country, and sometimes the cutoff varies as per the manufacturer's recommendation. So, a population-based specific cutoff has to be used, or the manufacturer recommended cutoffs need to be used to analyze these immune assay and immune precipitation tests. With regard to eosinophil, the eosinophils are the primary drive for ABPA pathogenesis, whether it's in the lung or the blood eosinophilia. And it can guide the treatment, especially to initiate anti-type 2 biological agents or for a combination therapy with prednisolone and itraconazole. And the recommendation is an elevated blood eosinophil level with a cutoff of 500 cells. The sputum eosinophilia may be more accurate marker of eosinophilic inflammation and can guide therapy. But in many practice settings, it might be very difficult to obtain a proper sample for doing the differential cell counts. The serum galactomannan actually has a very poor accuracy in testing ABPA, and it is not recommended for diagnosing ABPA. The specific immunological tests, especially the recombinant aspergillus fumigatus antigens, have been found specific for ABPA, especially the F1, F2, and F4, and the elevation of these particular recombinant antigens has been found very highly specific towards the diagnosis of ABPA. And these tests are not recommended for routine use because they are not widely available. And for these tests, the manufacturer recommended cutoffs may be suboptimal, and appropriate cutoffs should be derived for different populations. With regard to radiology, it is important that a high resolution CT scan with thin sections be used, and the high sensitivity and identification of the type and distribution of the bronchiectasis and recognition of mucus plugs are the advantage of CT over a chest radiograph. The high attenuation mucus, that is a mucus visually denser than the paraspinal muscles on a non-contrast thoracic CT, is pathognomic feature of a ABPA in a subset of patients, and the sensitivity and specificity of ham are 35 and 100% respectively. This is the finding of the ham depicted in a patient on the right side panel and bronchiectasis on the left side panel. With regard to chest X-ray, the findings may be a transient or fixed or fleeting opacities, and sometimes the radiology might even be a normal chest X-ray. And for the follow-up, a chest X-ray is what is recommended and not a CT for regular routine follow-ups. And doing an MRI of the chest is not a routine recommendation because it has no diagnostic advantage over a CT chest. About bronchoscopy, a routine use of bronchoscopy is not recommended for the diagnosis of ABPA, but in certain indications where the diagnosis is uncertain or if there's unexplained hemoptysis, or when there are sputum cultures which are not informative or cannot be obtained, the patient might have another chronic infection like TB or non-tuberculous infection, or certain indications where a therapeutic bronchoscopy is required, these are the specific times that a bronchoscopy should be done for patients with ABPA. So when you talk about the diagnosis of the ABPA, we have the essential components of the predisposing factors, the essential component of fungal sensitization, the serum total Ig levels more than 500, and the other components include the positive IgG against Aspergillus fumigatus and a blood eosinophil more than 500, along with the characteristic radiological findings. And there are some important considerations also which need to be considered. When you talk about ABPM, in addition to the specific fungus specific Ig level elevation and the total Ig more than 500, you have the characteristic predisposing factors as mentioned earlier, and any of the two components of either a positive fungus specific IgG, a blood eosinophil more than 500, two sputum or a one bronchoalveolar lavage sample showing the fungus culture showing the characteristic growth of the fungus, and a thin section CT scan with the characteristic findings. And the other important considerations also to be kept in mind when coming to a diagnosis of ABPM. So when we have the characteristic findings, we have to see what are the state of the fungal sensitization, whether it is present or absent, and accordingly see what is the serum total Ig level, the serum eosinophil levels, the characteristic radiological findings. And if the radiological findings are characteristic of bronchiectasis, no bronchiectasis, of mucus plugs, of ham, or chronic pulmonary fibrosis. And this is how we proceed with the diagnostic algorithm of ABPA and ABPM. And when we talk about the treatment response, this has also been changed because the earlier numbered stages have been removed and 5 categories have been renamed. That is the acute ABPA, the response, the remission, the treatment-dependent ABPA, and the advanced ABPA. What has been removed is the asymptomatic stage and the glucocorticoid-dependent asthma. And what has been included is a newly diagnosed ABPA and an exacerbation together as an acute ABPA. So these are the features of the acute ABPA, the response, the remission, and the treatment ABPA, and the advanced ABPA, which leads on to chronic type 2 respiratory failure. So when we talk about what's next is over to the treatment, which will be dealt in the next talk by my next speaker. So once again, I thank the CCI for this opportunity for giving me this talk, and we'll have further discussions about the evaluation of ABPA during the panel discussion. Thank you.
At the very onset, I would like to thank the entire organizing team of CCI for having me over for this webinar today. A special thank you to Dr. Nagarjuna Maturu for this wonderful introduction. My talk has been made very easy by Dr. Gayathri, who so expletively expressed the classification criteria and the clinical staging for ABPA. So my topic today is the treatment and follow-up of ABPA. Before moving on to the details, we would just pass briefly on the principles of treatment and the treatment goals of ABPA. So the principles of treating ABPA involve using anti-inflammatory agents to control immune responses or antifungal agents to decrease airway fungal colonization. Similarly, the treatment goals are symptom relief, improving asthma control, preventing asthma and ABPA exacerbations, abrogating bronchiectasis progression, and minimizing therapy-related adverse effects. Now, we'll be looking at the treatment of ABPA according to the clinical stages of ABPA. So, coming first to acute ABPA, very important to remember that an asymptomatic ABPA patient should never be treated with systemic therapy. A ABPA-S should be treated with systemic therapy only if there is poor asthma control or recurrent exacerbations despite asthma therapy. A low to moderate dose of prednisolone or not and or oral itraconazole for 4 months is recommended as the initial therapy for treating acute ABPA. The latest ESHAM consensus guidelines give a protocol of how the prednisolone can be used and tapered over the course of 4 months. We begin with 0.5 milligram per kg body weight per day for 4 weeks, move on to 0.25 milligrams for the next 4 weeks, 0.125 milligrams for the next 4 weeks, and then we taper by 5 milligram per week to complete the 4 months duration. Remember that oral itraconazole is recommended as the initial therapy where systemic glucocorticoids are contraindicated. During the course of the slides, we'll also come and I'll tell you where we can use both prednisolone and itraconazole. So coming on to the evidence for the use of oral itraconazole as a steroid-sparing agent in the treatment of acute ABPA, Peter Wack, way back in 2003, conducted an RCT, and he concluded that itraconazole treatment of subjects with stable ABPA reduces eosinophilic airway inflammation, systemic immune activation, and exacerbation. And this RCT really put itraconazole on the forefront for managing stable ABPA patients. Now, another very important concept which we should remember is that, is there a role of high-dose ICS in the management of acute ABPA? Now, the OG ABPA group from PGI Chandigarh opined that high doses of ICS alone have no role in the management of ABPAS and should not be used as first-line therapy. Now, in patients receiving OCS or alternate therapy, ICS can be used as an add-on therapy for the control of symptoms of asthma only. Now, a combination of itraconazole and glucocorticoids, like we had put earlier, as first-line therapy for acute ABPA is not recommended. However, a short course of glucocorticoids may be used as initial therapy along with itraconazole if we are going ahead with itraconazole as the initial therapy. Similarly, oral voriconazole, posaconazole, and isavuconazole should not be used as first-line agents for treating acute ABPA, and this may be used if there are contraindications to systemic glucocorticoids and intolerance, failure, or resistance to itraconazole therapy. Now coming on to the treatment of ABPA exacerbations. An acute ABPA exacerbation is treated in the same manner as newly diagnosed ABPA. A combination of oral prednisolone and itraconazole should be used for treating recurrent, which are defined in the latest ESHAM consensus as more than equal to 2 in the last 1 or 2 years ABPA exacerbations. A very important point to remember is that biological agents or nebulized amphotericin B is not recommended for treating acute ABPA exacerbations. Now, do we have any evidence for using a combination of oral prednisolone and itraconazole for treating recurrent ABPA exacerbations? So unfortunately, there are no RCTs for managing ABPA exacerbations, and it's mostly an expert consensus which dictates the treatment of ABPA exacerbations, especially the recurrent phenotype, with a combination of both prednisolone and itraconazole. Now, how do we monitor treatment response once we initiate a patient on ABPA therapy? So the initial treatment response is measured after 8 to 12 weeks using a combination of clinical, immunological, and imaging features. A good response is indicated by a major improvement in symptoms, Likert scale or a VAS of more than equal to 50 objectively, chest radiograph, along with at least a 20% reduction in serum total IgE levels. Again, here it's very important to remember that Aspergillus specific IgE and IgG, AEC, or total IgE. Hello? Again, it's very important to remember that Aspergillus fumigatus specific IgE and IgG, AEE, and IgE against recombinant antigens are not recommended for response assessment. Now, moving on to the management of treatment-dependent ABPA. Now, long-term itraconazole, nebulized amphotericin B, or biologicals are recommended options for managing treatment-dependent ABPA. Coming on to management of ABPA in remission, patients in remission should be managed for underlying asthma and bronchiectasis as per the existing guidelines. And in patients achieving remission with antifungal azoles or biological agents, periodic assessments to determine the need for these therapies is recommended. Similarly, extensive bronchiectasis or advanced ABPA should be managed with long-term oxygen therapy, vaccination, and lung transplantation, which are standard guidelines from other pulmonary disorders. Uh, I would not talk about treatment of all the special conditions, but a special mention should be given to ABPA during pregnancy because this, I feel, in our clinical practice is a very common subgroup. So, systemic glucocorticoids for managing acute stage or treatment-dependent ABPA in pregnancy should be the norm. Avoid the use of biological agents or oral azoles for managing acute stage or treatment-dependent ABPA in pregnancy. Now, the latest ESHAM consensus statement say that ABPA should also be treated according to the genotypic presentation that the patient comes with. So, for example, if the patient has an eosinophilic predominant ABPA, we should prefer steroids over antifungals. But if a patient has a neutrophilic predominant ABPA, we should go ahead with an antifungal over steroids. So this is still a matter of debate. Not a lot of people would expect that or would bring it into their clinical practice. But this is what the consensus guidelines are saying, and Dr. Nagarjuna would obviously put more light into it while we discuss during the panel. And in the end, I would just leave you all with this treatment table, a flow chart, which is again adopted from the Isham consensus. I would not go ahead and read it. It has everything which I just presented during the past 10 minutes or so. And I'm sure we're going to have an elaborate discussion of each and every point during the panel discussion. So at the end, I would just take a moment to thank all my alma maters. Thank you.
Thank you so much, Gayathri Madam and Dr. Abhishek for two very informative yet crisp talks on screening and diagnosis of ABPA and on managing ABPA. I think with this, we will go to the more important part of today's webinar, that is the panel discussion. So I think we have all the 5 panelists eagerly waiting to share their experience. So though I will be asking the question to one doctor, but I think if anyone of the panel wants to answer, I think you can raise the hand, and then it should be more of a discussion so that we'll be giving the best possible answers to the questions which we have. So starting off, let me start with the basics. Some of the points may be a repetition from what the speakers have spoken, but I think the more we repeat, the more we stress, the more we drive home the message. So the first question would be to Dr. Mir Faisal. So can you tell our audience on very briefly about the etiopathogenesis of ABPA?
Thank you, Dr. Nagarjuna, for the question. I think it has been already explained by our eminent speakers. ABPA is a complex hypersensitivity reaction in response to colonization of airways by the fungi, by Aspergillus. That occurs actually almost exclusively in patients with asthma or in patients of cystic fibrosis. So, in chronic cases, we have then repeated bronchial obstruction, we have inflammation, and we have mucoid impaction of the bronchiole. So what happens basically is there is mucoid impaction of the bronchi, and then there is an eosinophilic pneumonia and bronchocentric granulomatosis. In addition to the histological features of asthma, if the patient has asthma. So we have eosinophilic pneumonia, which is present there. We have which is a major feature of the disease, and then there are we can find septate hyphae in the bronchial lumen because of the fungi. But pathogenesis, if we want to know the pathogenesis, it is incompletely understood as of now. There is actually no relation between the intensity of the exposure of airborne Aspergillus spores and the rate of sensitization to the fungus. Actually, the spores, in fact, the inhaled spores that are inhaled in sufficient quantities, any number of sufficient quantities can behave as allergens, and normal and in low level and normal or low level of IgE against the fungal antigens can be seen. In contrast, when the exposure is in atopic individuals, in individuals who already have some disease like asthma or in cystic fibrosis, then the fungal spores or the mycelial fragments can cause formation of IgE and IgG antibodies. There are T cells which also play an important role. So all the pathogenesis there helps all these cascade of events cause mucoid impaction, and then there is remodeling of the bronchioles, and we do have at a later stage we have a bronchiectasis which also sets in. So this is how the pathogenesis, this is how the disease moves forward in from fungi.
Thank you so much, Dr. Mir Faisal. I think if I have to summarize, there's an environmental factor and a host factor. Environmental factor being exposure to the Aspergillus, which, as you rightly said, is ubiquitous. But if you do not have the host factor, that is the person sensitizing to the colonized Aspergillus, the ABPA won't develop. So it is just that a subset of people, for reasons which are not very, very clear, develop sensitization to this Aspergillus which we inhale. So there is colonization, then sensitization, and then the disease. I think very rightly said Dr. Mir Faisal. So this is just to start the framework for the further discussion. So we're having a lot of questions coming in. We will try to take up as many as possible. So now, before we go on to the discussion about ABPA per se, there is one thing which we all have to understand: Aspergillus and human body interactions are very strange. So Aspergillus, as we all know, can cause a lot of types of pulmonological problems. ABPA is one of them. So as we all know, Aspergillus can just be a colonizer. It can lead to saprophytic colonization in the form of a fungal ball. It can lead to invasive pulmonary diseases, acute and chronic, and it can lead to allergic diseases, that is one of them being the ABPA. So now I would ask my dear friend Dr. Mahavir Modi, so as a clinician, if we isolate Aspergillus from the sputum, or we're thinking of the relation between Aspergillus and the lung, so how do we differentiate the aspergilloma, that is a saprophytic form, invasive aspergillosis, and allergic aspergillosis? Just brief pointers on how can we go about differentiating them.
Yeah, thank you, Nagarjuna, and thank you, CCI. I think it's a wonderful topic, and it made me read a lot of things, and the criteria are definitely evolved a lot, and it is definitely going to be a practice changing session for all our attendees also. So as you said rightly, it is Aspergillus. If we find in the sputum of a normal healthy individual, it doesn't carry much significance because it can be just a mere colonization. Then it comes like we have patients of maybe old tuberculosis for years together, and they have a fungus ball on their X-ray, and we know that nothing to be done for these patients, so they can be just a aspergilloma. And this is classically seen in CT scans as well as on the X-ray. We don't see aspergilloma as commonly as we used to see in the previous days. But still, if you have any patient who's coming only with a hemoptysis and otherwise no clinical symptoms of systemic symptoms, so I think there is a clinical case of aspergilloma. The third category of patients is where a patient who's asthmatic, and then they're developing typical bronchiectasis on the X-ray, or if they're having eosinophilia, raised Ig levels, and aspergillus specific Ig also is positive. So these are the patients, those who are specific of allergic bronchopulmonary aspergillosis, ABPA. The fourth category of patients are basically chronic necrotizing pulmonary aspergillosis, where it's a locally invasive disease. So it may be a patient who is having a pre-existing COPD or pre-existing bronchiectasis, and in these patients, along with that cavitating fungus ball, along with that there may be some pericavity infiltrates, and these patients, they may develop a locally invasive chronic necrotizing pulmonary aspergillosis. So in these patients, if you find aspergillus in the sputum, then it does carry some significance. But the most important factor whenever we find aspergillus in the sputum is to find out if the patient's host system or the immune system is intact or not intact. If the patient's immune system is not intact, then that's a time. For example, if you have a patient who's having organ transplant recipient, or if a patient who's having steroids, the patient who's on steroids, or if the patient who's who are on, just a minute, or the patient those who are on steroids or on some other immunosuppressive agents. And if these patients, they grew aspergillus in the sputum, along with that on the CT scans or on the radiologically, you find typical features, maybe halo sign, maybe presence of tracheobronchitis. So I think there are the ones where the sputum aspergillus it is very, very significant. And that can be diagnostic criteria in these patients with invasive pulmonary aspergillus. In patients with ABPA, presence of aspergillus growing on the sputum culture, it is not a very good diagnostic criteria. It is one of the minor diagnostic criteria, as Dr. Gayathri has given us a good outline about how do we diagnose these ABPA patients. So let us not give a lot of importance of growing aspergillus in sputum in patients with asthma or in patients with ABPA. But for other, especially the immune deficiency patients where we get aspergillus grown on the sputum. So I think that is something which we have to definitely give emphasis on. So I think these are 4 or 5 different categories of patients what we see with aspergillus.
I think Modisa very crisply told. So in fact, there are a couple of questions on aspergilloma, ABPA, invasion and all. So I think if I have to summarize, if you have to differentiate these various forms, I think we should look at 3 things. One is the clinical presentation. Second is the radiological feature. That is very important. And third is the host immune status, which you had rightly pointed out. I think the immune status of the host partly determines how a person will respond to the inhaled aspergillus. One thing which you have rightly said is never take a simple fungus in the sputum without looking at the whole picture, because it can just be an colonization of the airways without anything. So the one question on aspergilloma and ABPA, I think I'll just quickly recapitulate what Dr. Modi has said. So for a saprophytic form of ABPA, usually patients are asymptomatic and it only happens in a pre-existing lung disease. So the person has had past history of TB or bronchiectasis, you will have an aspergilloma, usually asymptomatic unless until they present with a hemoptysis. Correct. And also Modi sir has rightly said, depending upon the immune status, the level of immunosuppression, you can develop invasion. So usually patients of ABPA conventionally are immunocompetent. They're not immunosuppressed. Correct. So people of asthma, bronchiectasis, they're not immunosuppressed. That's why they develop allergic forms. Whereas if you have any immunosuppression, you can develop the chronic or the acute invasive aspergillosis. And he has also mentioned on the radiological pointers. So basically the radiology is completely different for the aspergilloma, chronic pulmonary aspergillosis, invasive pulmonary aspergillosis, and ABPA. I think that is something which we all should recognize, that by looking at the clinical features, radiological features, immune status of the patient, we can easily differentiate the various forms of aspergillus affecting the lungs. So, but if I think that invasion and aspergilloma is a different topic altogether, but I think we should come and focus on the point of interest, that is ABPA. So before we go on to the aspects of diagnosis per se, I will ask Dr. Gayathri Madam, how about the clinical presentation of ABPA? So how does ABPA present? What are the normal clinical presentations? Or are there any clinical pointers where you would strongly suspect a person to have ABPA?
See, as mentioned earlier, most of these patients have a background chronic lung disease like asthma or bronchiectasis, and some of them may have conditions like cystic fibrosis. But more importantly is their failure to respond to the usual asthma therapy. That is something very essential that we have to identify early. The other thing which I've seen in practice in general is the patients also have some risk factors also, which will make us suspect that maybe they have an associated ABPA. There might have been some exposure to some places where they might have been exposed to some fungi. Especially I've seen in civil engineers, they have some exposure to construction, building construction and dampness. I've seen these kind of ABPA episodes happen to them. They have been background asthmatics, but it had been a very tricky situation to diagnose them. So I think the history and the clinical presentation, and also some of the asthmatics also stop coughing out, plugs of mucus also. So all these are some pointers that we may be dealing with a ABPA.
Okay. Thank you so much, madam. I think the points which I get from your answer is that if a person has an uncontrolled asthma, I think that is the most common presentation of ABPA, and we should strongly suspect ABPA. That is one of the commonest presentations. In addition, madam has also said that if a person is coughing out thick, like mucus plugs also, that is another clinical presentation of ABPA. Also about the environmental exposure, yes, that is definitely there. People who are exposed to this fungus damp environment are more likely to develop ABPA. But I think the clinical presentation is pretty non-specific. So they usually present like a conventional asthmatic, but usually they have uncontrolled asthma. And the other thing which I would like to add is that if a person of asthma starts developing hemoptysis, that is another time when you have to think of ABPA. Now going on to suspecting and screening. I think Dr. Gayathri Madam also has briefly touched upon this point, but it is very important for the audience to know when and whom to screen for ABPA. I think I will ask Dr. Abhishek this question. So, what is the ideal target population for screening ABPA?
Sir, first of all, any uncontrolled asthmatic, like you rightly put, should be screened for ABPA. In fact, the latest ESHAM consensus say that all newly diagnosed asthmatics should be upfront screened for ABPA in case they are adults. In case of children, they have reserved a recommendation saying that only those with a difficult to treat asthma should be screened for ABPA. And similarly, this consensus has also expanded the population to asthma, bronchiectasis, COPD, and cystic fibrosis. So these are certain subtypes of patients. When they come to us in our clinical practice, we should have a high degree of suspicion of ABPA, and we should subject them to ABPA because it's very well known that if undiagnosed, it would lead to a irreversible state. A bronchiectasis would develop, and then from there on, it's a downward journey. So when we can prevent it, it's very important that we do so.
Yes. Thank you so much, Dr. Abhishek. So the target population for screening is obviously the predisposing disease, that is the asthma or bronchiectasis or so on and so forth. So in the guidelines, we have proposed that ideally, in an idealistic scenario, every person with asthma has to be screened for ABPA. What is the reason for us to say in India is that in India, ABPA is much more prevalent than several countries, though it is there across the globe. And whatever data, published data from centers is there, shows a very high prevalence of ABPA, though it is skewed by the fact that it is from tertiary care centers and we do not have population-based prevalence of incidence of ABPA. So though the guidelines say that ideally every adult asthmatic should be screened for ABPA, it should also be understood that practically it is not possible. So what I think as a group, we also said strongly that at least every uncontrolled asthmatic should be screened for ABPA. So if an adult asthmatic is uncontrolled, yes, I think we should screen for ABPA. And in children, it is the other way around. We had a group of pediatricians who were there in the guideline formation. So the consensus was that only uncontrolled or severe asthmatics in children have to be screened, not necessarily everybody, because the data on prevalence of ABPA in children is still lesser than what it is there in adults. This is about asthma, but at this junction, I would also like to add one point that in bronchiectasis also, all the guidelines, international guidelines now consider ABPA as a treatable trait. So in most of the webinars, we always say that asthma, you screen for ABPA. Now any adult or adult bilateral bronchiectasis has to be screened for ABPA. So that is another target population for screening. So that person may not come with a history of asthma. They may present as bronchiectasis, and to diagnose bronchiectasis, you should screen for ABPA. So the two target populations where we have to screen are Uncontrolled asthmatics, definitely yes, ideally every asthmatic, and every undiagnosed or diagnosed case of bronchiectasis, we should screen for ABPA. In fact, even if it's a diagnosed case of bronchiectasis, cystic fibrosis, he can have a secondary ABPA. An undiagnosed case of bronchiectasis can have ABPA as the cause. So that is the complex relationship between bronchiectasis and ABPA. I think this is a very important question for every one of us, because unless until we suspect ABPA, unless until we screen ABPA, we will not be able to diagnose the disease. So I think this is important that in our clinical practice, both asthma and bronchiectasis are very common. So I think we should make it a habit to start screening ABPA patients. It's ABPA in all our patients of asthma from tomorrow. I think most of us already do, who are not doing have to start doing it. Now coming back to Dr. Mahavir ji about how to screen. Now Dr. Abhishek has told us when to screen. Now the question is how to screen. So what is the ideal screening test for ABPA? This has been covered, but I would also request you to brief about what is the ideal screening test for ABPA.
Yeah, thank you for the question. I think Dr. Gayathri has clearly said that nowadays for screening ABPA, we should be using Aspergillus fumigatus IgE. That is the test which has been recommended. And there are different cutoffs, but the cutoff of more than 0.35 is said to be quite diagnostic that the patient is sensitized to, or that can be one of the first option to diagnose these patients with ABPA. Although in our clinical practice, up till now, we are doing total IgE values, and we know that total IgE sometimes can be, they can be very high, and they may not be actually giving us any clue about whether patient sensitive to one particular fungus or it is the total allergy level against all kind of allergens. So it may be fungus, it may be pollen grains, it may be food allergy. In everything, the total IgE value will be high. But if you want to specifically screen for ABPA, I think IgE specifically against Aspergillus fumigatus, that is the commonest test what we should be using. Another test along with this, sometimes if it is not available and if certain labs are not doing this test, then you can do a skin prick test. So I think although skin prick test again can be of similar value as compared to this specific IgE, but still the specific IgE is the first option, and if it is not available, then one can do a skin prick test. And many of the times, I think we can also do a CT. So CT can be again quite diagnostic in these patients. So I think my first test will be IgE specific for Aspergillus, and the second test will be doing the CT and then to find out bronchiectasis, presence of high attenuation mucus, or maybe filtering opacities on the radiologically on the X-ray or on the scan. So I think these are the ways by which we should be able to screen majority of our patients for ABPA.
Yes. Thanks a lot, Dr. Modi sir. So I think we all agree that Aspergillus fumigatus specific IgE is the test which is currently proposed as the ideal test for screening. So ideally, an ideal test is something which has very good sensitivity. So it should not miss the disease in a person. That is an ideal test. So the sensitivity of specific IgE in picking up this thing is to the tune of 98%. I think that is the reason why it has now been chosen. And also it is a test which is available. It is just that we may have to send it outside if it is not there in-house. But every city, I'm very sure there are labs which are doing this test. So please do not think it is not there. Every city has labs which are doing this Aspergillus fumigatus specific IgE. And Dr. Modi sir has also said, in case it is not there, as a second option, you can use Aspergillus skin prick testing. Though now the data clearly says that skin prick testing is less sensitive than specific IgE, but if you don't have access for whatever reason, you can still do a skin prick test. Total IgE is also things which is very often done by most clinicians. But again, Dr. Modi has rightly said that it may be sensitive, but it doesn't have specificity. So IgE level can be elevated in a lot of allergens, lot of diseases. So IgE may be sensitive, but definitely it is not specific enough. So I think we now know whom to screen and how to screen. I think that is the first thing. So once we screen the patients, obviously we will follow the algorithm for diagnosing ABPA in people who are sensitized to Aspergillus fumigatus. Now in the algorithm comes the other tests, that is the total IgE, eosinophils, specific IgG, and radiology. So here I would like to take inputs from our radiology colleague and expert, Dr. Nikhil, on certain important points on radiology. So the first question I would ask is the high attenuating mucus. This is something which is given a lot of importance, and yet till date there are many times it is missed on a CT, probably because lack of awareness. I think Dr. Modi is also agreeing with me that till date also this is missed. So can you educate us on how to pick up HAM on radiology and what is its importance?
Good evening, everyone. Thank you, sir, for this wonderful question. Thank you, CCI, for giving me this opportunity. I would like to share some slides with you on this.
Sure. I think it is important if we see it also. Correct.
So high attenuation mucus it can be picked up on NCCT as it is visually denser than paraspinal or skeletal muscles on NCCT and has HU value more than 70. It is pathognomic even if all the serological criteria are not fulfilled. It is generally seen in around 28% of patients. It has a low sensitivity of around 35%. However, high specificity of 100%. And it is a predictor of a poor outcome. This paper here showed that HAM infection in ABPA is associated with initial serological severity and frequent relapses, but does not seem to influence the complete remission. This is a case showing high attenuation mucus with HU value of around 110. This is a case showing high attenuation mucus with attenuation more than the thoracic muscles and paraspinal muscles. So it is hyper attenuating, more white than these muscles. There are no general differential diagnoses for HAM. However, for mucoid impaction, we should consider the mucoid impaction secondary to bronchiectasis due to any other cause other than ABPA, secondary to an endobronchial lesion, and secondary to an atretic bronchial segment. Thank you.
Yeah. Thank you so much for the images. I think one thing which all the pulmonologists should know is that it should be seen on a non-contrast CT, not on a contrast CT, and in the mediastinal windows. I think 2 days back also, there was a diagnosis on a contrast scan. So I think for diagnosing HAM, it should be a non-contrast mediastinal section. Am I correct, Dr. Nikhil?
Yes, sir.
Yes.
Definitely.
And he has given two scenarios. One, if you have the Hounsfield unit, so if you're seeing on a console, you can probably put the cursor and get the HU more than 70. But if you only look at the film where you don't have the HU, you compare with the paraspinal muscle and see if it is more dense than the paraspinal muscle and skeletal muscle. Correct? So yes. I think that is it. See, once you start looking for it, it is not easy to miss. I would say it is not easy to miss. It is only that if you don't start looking for it, you will miss it. Now coming back, Dr. Mahavir Modi. So what is the clinical as a clinician? Now as a radiologist, Dr. Nikhil has picked up HAM. He's already told a couple of very important points. So what is the clinical significance of HAM? Why are we giving so much of importance to HAM?
Yes. So as Dr. Nikhil has rightly said that it has a very good diagnostic rate, and almost when we have a high attenuation mucus, then that actually can confirm presence of ABPA, even if the other features are not falling into place, or even the other criteria are not falling into place. So that much is the significance of this high attenuation mucus. So as a clinician, whenever we get these patients, those who have this high attenuation mucus, they are the one where they can get heavily colonized with fungi. That is one thing, because and they have very viscid kind of sputum which they are not able to expectorate out completely, and it becomes a challenge because not only the fungal colonization, but then it can get super infection with the bacteria as well as with the viruses, mycobacteria. So those all challenges can be there, especially when we find these kind of patients with high attenuation mucus. Again, it becomes quite challenging for a clinician when we have this ham sign positive and a patient who has allergic bronchopulmonary aspergillus, because they are clear-cut candidates for glucocorticosteroids, and especially these are patients those who may exacerbate more frequently in our clinical practice. So I think that is one of the very, the key sign for ABPA, what I will say in my clinical practice. And these patients are very difficult to treat because of the viscous sputum, which they are not able to bring out. And we may have to use certain kind of measures, especially maybe physiotherapy measures or some postural drainage, or giving some kind of equipments for these patients, or increasing their hydration, as well as using certain kind of devices like aerobica or aquapella, so which can help them to bring out this sputum in these patients. Am I right, Dr. Nagarjuna, or
Yes,
anything
yes,
else
yes.
you want?
So I think a couple of things again I will retell, because of the fact that very important is the fact that it has 100% specificity. So if you find ham, it has to be ABPA or ABPM. Even if no other criteria are satisfied, even if IgE levels are low, you can still diagnose ABPA. That is an exception given to ham. Second is it's a direct marker of immunological severity. So high, if you have ham, very high, you can expect very high eosinophil counts and very high IG levels. There are a lot of studies backing it up. And Dr. Mahavir Sahib has rightly said, it is a predictor of exacerbations. People with ham develop more exacerbation. So you should be more aggressive in treating ham. And also, obviously, because mucus plugs are there, it will lead to a lot of other issues associated with mucus plugs. I think we have a lot of questions, so we should be quick bit faster. So next question again to Dr. Nikhil is, we have discussed about ham, which is very specific but not very sensitive. Only 25% or so will have the ham on the CT scans, correct? So what are
Yes.
the other radiological findings and the new criteria, radiological criteria for classifying ABPA? Very quickly.
Thank you, sir, for this wonderful question. I am again sharing some slides with you. The radiological diagnosis of ABPA, now it is recommended that a baseline CT is important for diagnosis, assessment of bronchiectasis, and prognostication. MR has no extra benefit over CT. Fleeting opacities on chest X-ray have high specificity, so it is a new addition to guidelines. The chest radiographic findings are transient findings and permanent findings. The transient being patchy areas of consolidation, radiological infiltrates, which are known as toothpaste or gloved finger shadows due to mucoid impaction in dilated bronchi, or collapse. Then uncommon being bronchial wall thickening, air fluid levels from dilated bronchi, perihilar infiltrates, massive consolidation, small nodules, and pleural effusions. The permanent changes are central bronchiectasis, parallel line shadows, ring shadows 1 to 2 centimeter in diameter, and pulmonary fibrosis, late changes being cavitation, contracted upper lobes, and localized emphysema. The uncommon being pleural thickening, mycetoma, and linear scars. The HRCT findings can be divided into bronchial, parenchymal, and pleural findings. The bronchial being bronchiectasis, dilated bronchi with or without air fluid levels, totally occluded bronchi, bronchial wall thickening, parallel line opacities, which are extending to the periphery, and high attenuation mucus plugs. The parenchymal findings being consolidation, non-homogeneous patchy opacities, parenchymal scarring of varying extent, segmental or lobar collapse, cavitation, and emphysematous buildup. The pleural being pleural effusion, spontaneous pneumothorax, bronchopleural fistula, pleural fibrosis, and pleural thickening. The uncommon being high attenuation mucus and pleural involvement, also randomly scattered nodular opacities. This is the table showing revised ISHM guidelines for radiological classification. I'll show you with the images. So this is the first, that is serological or ABPA-S with no bronchiectasis. It shows multiple central lobular nodules. However, no bronchiectasis can be seen in this scan. And this is the second, which is ABPA-B or radiological evidence of bronchiectasis. Here we can see central bronchiectasis seen bilaterally. Then coming to ABPA with mucus plugging, ABPA-MP. So these patients have bronchiectasis and mucus plugging. These are the mucus plugs which has attenuation similar or lower to the muscles. You can see it here in this mediastinal window. And this is ABPA-HAM, as we have seen this case earlier also. So this is higher attenuation mucus plug with attenuation more than chest wall or paraspinal muscles. This is ABPA-HAM. Next is chronic pleuropulmonary fibrosis or CPF. These should have two or more of the following findings: pulmonary fibrosis, fibrocavitary lesion, fungal pall, and pleural thickening. So we can see fibrosis here and pleural thickening here and a small cavity here. So this case has all these findings. Then some of the other features like consolidation, central lobular nodules, atelectasis, mosaic attenuation, and other common radiological features which we have discussed can occur in isolation or in presence of bronchiectasis, mucus plugging, and HAM. In patients with CPF, chronic pulmonary aspergillosis complicating ABPA should be excluded. Then this is another type of ABPA called advanced ABPA, in which cor pulmonale or type 2 respiratory failure can be seen with extensive bronchiectasis in more than 10 segments. Then poor prognostic factors are extent of bronchiectasis, HAM, any fungal ball. These are the independent predictors of recurrent ABPA exacerbation. The differential diagnosis of central bronchiectasis, we should also consider congenital tracheobronchomegaly or Munier-Kuhn syndrome, cystic fibrosis, or William-Campbell syndrome, which is very rare. So these are all the findings in this table. Thank you.
Thank you so much. I think this speaks volumes about the myriad ways an ABPA can present to us. So you can have airway signs, you can have parenchymal signs, you have pleural signs, so on and so forth. There's one question: can we detect ABPA on X-ray? I think there are only two instances where it has a significant impact. One is fleeting pulmonary opacities. If you have that in an asthmatic, strongly suspect ABPA. Second is if you have finger in glove sign. I think Dr. Mahavir sir, anything else you wanted to say?
No, finger in glove.
Yes, finger in glove and fleeting pulmonary. These two things you strongly suspect. In the remaining cases, it will add to the suspicion, but you cannot diagnose ABPA based on X-ray. I think Dr. Nikhil has elaborately told about the manifestations. One thing I would say is that compared to the old and the current ISHAM, there is one new group, that is the ABPA-B with MP, without HAM. So even if there's mucus plugs without HAM, it is given a separate criteria, separate cutoff, because of the extensive work done with the Japanese in this group. That is what Dr. Mahavir Modi also has rightly said. That is, mucus plugs, if they are there, it is a marker of disease activity. If HAM is there, it is even more considered more active. So I will not waste much time because we can keep talking about this. So next very, very important and practical thing for all of us is the cutoffs. Many times we get confused with the cutoffs which are proposed, the lab values and so on and so forth. So for the 4 common tests which are used: IgE level, Aspergillus fumigatus specific IgE, Aspergillus fumigatus specific IgG, and eosinophil count. Gayathri madam, what are the units? What is the cutoff? What is the ideal test which has to be done? This is just very crisp for us to recapitulate.
See, for the Aspergillus specific IgE level, the cutoff is 0.35. So that is what we are focusing. If it is more than 0.35, it is more in favor of ABPA. Less than 0.35, it is not related to ABPA, maybe ABPM. That is one thing. With regard to the serum IgE level, the earlier ISHAM guidelines kept the value more than 1000, but now it has been reduced up to 500 now. Okay. And with regard to the Aspergillus specific IgG values, that actually surprisingly it's a country to country variation in the values. So they have values for India, which is more than 27, for Japan, around 47, and more than 60 for UK. And also there's a clause in this guidelines that look at the manufacturer's recommendations as well. So that is one thing which we also have to look into. And with regard to the serum eosinophil count, it's more than 500.
Correct, madam. So I think just for everyone to understand, the cutoff which is there on the test may not be the cutoff which is used for diagnosing or screening ABPA. Correct? And also you should give a note to the unit which is there. For Aspergillus fumigatus specific IgE, it is KUA per liter. That is kilo units of Aspergillus antigen per liter. That is KUA per liter. And most of the labs will have 0.1 as the cutoff, more than 0.1 positive, less than 0.1 negative. But for ABPA, diagnosis is 0.35, which is used for screening and diagnosis. For total IgE, the unit is IU per ml. The reason it is important is some labs earlier used to give a nanogram per ml. So it is IU per ml. And as madam has rightly said, the cutoff has been brought down to 500 from 1000. So now it is 500 IU per ml. Then the confusion comes with specific IgG. So specific IgG also, there are immunoassays and immunoprecipitants assays. So nowadays it is recommended that you use FEIA, fluorescent enzyme linked immunoassay, ideally if it is available, and it is MGA per liter. So each test has a different unit. And for specific IgG, as of now, in India, it is 27, but ideally the country-specific cutoffs have to be used unless until there is a global consensus. Correct. So I think this is something which, when we are looking many times, because this is the problem which we see also. When people diagnose ABPA, if you don't know the cutoff, you tend to use the lab cutoff. So that again will lead to problem. This is the reason why we thought that this is important for everyone to know that each lab, each test has a particular method, particular unit, particular cutoff for use. Eosinophil count is 500 cells per millimeter cube. Again, here the thing is it can be current or past. So only for eosinophil count, you can use even past eosinophilia as one of the criteria, not exactly the current date's eosinophil count. I think next we will go on to I think we have only 20 minutes left. I think we should now start focusing on the treatment of ABPA also. I think now that we have screened, we have diagnosed ABPA as per the criteria which have been laid down. Now, how do we decide on therapy? Now, I'll ask Dr. Mir Faisal. So for a newly diagnosed symptomatic ABPA, that is so-called acute ABPA, Dr. Abhishek has said about the various options which are available, but in a particular patient, how would you decide which is the correct thing for the person? Would you give steroids? Would you give antifungal? Or would you give a combination?
Yeah, it depends upon the patient actually. If we have a newly diagnosed patient, I think in clinical practice we then decide in patient to patient basis, because if we have a patient of ABPA and he has asthma also, I think the steroids and the dose of steroids also is a bit higher, and then we start with steroids. And if the patient has more of bronchiectasis, more of and we feel that there's a fungal infection is more, so we can start it, as Dr. Abhishek already said in his talk. So in patients where the diseases more, we start with a combination of steroids as well as the antifungals, and the dose, as Dr. Abhishek already said, that we start with 0.5 of per kg of prednisolone, and then taper it for 4 to 6 weeks to 3 months, and same with the case of itraconazole or antifungal. I think it becomes more of what is more important is then treating patient as a patient, because if a patient has more issues of breathlessness, then I think starting with steroids is a better option. I think you can put on more light on the.
Yes, sir. I think one thing which Dr. Mir Faisal has rightly said is we have to personalize the therapy. I think that is what sir has rightly said, because the guidelines also now give an option. You can choose steroids or antifungals, because till 5 years ago, only steroids were considered the treatment of choice for ABPA. Till the RCTs have come, 2 landmark RCTs, both from Dr. Ritesh Agarwal, have clearly shown that itraconazole monotherapy or voriconazole monotherapy can be as effective as steroids, oral corticosteroids, in treating newly diagnosed acute ABPA. So I think Dr. Mir Faisal is correct in saying that we have to choose the correct option as per the patient. I think from what I do, I think Dr. Mahavir, Dr. Abhishek, Dr. Gayathri Madam can also pitch in. This is a very important question. So what I do is, if the person has any contraindications to steroids, then I would definitely give antifungal, itraconazole or voriconazole. If the person has no contraindications to steroids, because of the fact that we have a much longer experience with steroids being the treatment of choice, we would still give steroids. And however, the dose is low dose. We don't go beyond 0.5 mg per kg and taper it and stop it in 4 months. I think this is what I follow for a newly diagnosed ABPA. Any comments from Dr. Gayathri or Dr. Mahavir? How do they decide it, steroids versus antifungal?
So you rightly said, because even I do, especially if the patient has some complications of steroids, or a patient who's diabetic. And sometimes we get patients, those who have so much of bronchiectasis that they don't have only aspergillus, but they have polymicrobial infection, especially those who are COPD. So they have pseudomonas, multi-resistant pseudomonas, and in these patients giving steroids, and that also in a very high dose, I also don't go beyond 0.5 mg per kg because it is very difficult for us to give 1 mg per kg and those kind of higher dosages for these patients. So in these patients, even I start with itraconazole, maybe steroids along with antibiotic coverage. But as far as possible, I will try to restrict steroids for not for each and every newly diagnosed case of ABPA. That is for someone who is exacerbating again and again.
Yes. So I think whenever we're worried about the side effects of steroids, we can choose antifungal monotherapy as the initial treatment of choice. Correct? That is there. And are there any? I think there was also some discussion on combination therapy. When to use steroids plus antifungals? Can we use them in the first episode? Should we only reserve them for use later on? Dr. Abhishek has touched upon some of the important points, but anyone else wants to pitch in and say. So is there any role for upfront combination therapy? Gayathri Madam or Dr. Mahavir, anybody can answer. So is there any clinical condition where you would want to start upfront combination therapy?
Sometimes we get patients with hemoptysis. So again, this is a category of patients with ABPA with hemoptysis where I like to give them upfront both the therapies, or if they have extensive disease. And so I mean, those are the patients where upfront, even if it's the first episode and he's come with hemoptysis and extensive disease, I will like to do combination therapy.
Correct.
Even in the first go of.
Yes. So I think I would also agree. In general, I think we should not give for everybody upfront combination therapy. So the guidelines clearly say combination is reserved from the second relapse. Newly diagnosed, first relapse, monotherapy, second relapse, combination therapy. But there is also a quote, a line which states that if a person has a very severe disease to begin with, you're picking him up at a stage where a lot of bronchiectasis has developed, as Dr. Mahavir Modi has said, on a compassionate ground, you can start upfront combination therapy. Second, Dr. Abhishek has very rightly mentioned that the time to respond with steroids is faster than the time to respond with antifungals. Though at the end of 4 months, the outcome will be the same. Correct? So whenever you're starting a person, very symptomatic person on antifungals, some experts would add steroids in the first 2 weeks. This is only to control the symptoms. Am I correct, Dr. Abhishek? This is what you had said, na? To control the symptoms, but stop it off fast and then continue antifungals. So this is also something which has been approved in the current guidelines. Basically, what has been followed and what people felt, what experts felt can be done. So that is about combining steroids and antifungals. Then, if at all we choose antifungal, that is itraconazole or voriconazole. These are the two for which where we have RCT evidence. I'm very sure for posaconazole or isavuconazole, maybe in the future you might develop, you might get some evidence. So how do you choose between them, and what is the ideal dose for these antifungal agents? Again, this I can ask Dr. Abhishek to answer. So do you have any clinical scenarios where you might want to prefer one antifungal over the other? I know that I'm asking a question for which there is no data, but this is a discussion. Dr. Abhishek, we cannot hear you. We cannot hear you. No, I think there is some problem. I think Dr. Gayathri madam can cover for Dr. Abhishek. So itraconazole versus voriconazole. So can we choose one over the other?
I think both the antifungals are time tested in treatment. I can't say that the right hand is better.
Madam, you've gone on mute.
Okay. I can't say that we can choose one as more superior to the other. But being a new agent, I think voriconazole, I have found a better experience in treating the patients with for ABPA. And I also agree with you that as a first-line therapy, I would rather give an antifungal rather than giving steroids. And even the shorter course of steroids, which you had mentioned, I'm a bit cautious about giving that in the earlier stage. I'm not very keen on that because there is always a fear that once you stop that shorter course of steroid, there might be an exacerbation. And then do we count that as an exacerbation, or do we count that as a failure to respond to steroid to the antifungal therapy? So all those questions have always come up in the therapeutic options actually. So I'm a bit cautious about that option. But I would say voriconazole much better off.
Yes, Dr. Mahavir, sir, please.
Yeah. I mean, it's a definitely challenging question, and there is no data for this. But we know that ABPA sometimes if the patient is highly immunocompromised, then this ABPA can convert to invasive pulmonary aspergillosis. And we know that for invasive pulmonary aspergillosis, we don't have data for itraconazole, but here the drug of choice becomes voriconazole. So if you have these kind of cases where you have a long, immunity is less and a person with ABPA has a chance of developing allergic invasive pulmonary aspergillosis. I think these are patients where we can still use voriconazole. I will give you an example. Recently, we had one patient. He had allergic fungal sinusitis and he had ABPA. And then he developed this H1N1. And outside hospital, along with his oseltamivir, he was put on very heavy dose of methylprednisolone, 500 milligram per day. And by the time this patient came to us and we did his CT, so this ABPA which he had in his previous CT, it had converted almost to invasive pulmonary aspergillosis. So I think these are the category of patients where we tend to give voriconazole instead of itraconazole. That is how I think I would like to cover up. Dr. Nagarjuna, your opinion on this?
I think the whole point of asking the question is to bring about the variability in the approach to treating a patient with ABPA. I think this has been subject to national surveys also. So though no everybody is correct, so I think the point to be taken home is that you can use itraconazole or voriconazole. There is no data. Whether you want to choose itraconazole or voriconazole would depend upon your experience, the ability of the patient to bear the cost, the drug-to-drug interactions, which are probably more with voriconazole than itraconazole, and also the fact that itraconazole has a very variable absorption. So there is one very good question in the poll, in the question chat box, that what is the ideal dose for these antifungal agents? Though the guidelines and everybody says it is 200 milligrams twice a day, there is a rider that when we give antifungals, you should do therapeutic drug level monitoring. This is something which is done only at some centers. It is not that, again, it is not available. Most commercial labs do therapeutic drug level monitoring for voriconazole, and if you ask for itraconazole also, they do it. It is just that we have to ask them to do, and it has to be in the range. So though it says 200 milligram twice a day, if the drug levels are suboptimal, you might have to hike up the dose in this particular individual. I think this is about the dosing of antifungals. We should always monitor them. And also there was a publication recently from PGI again, which has caught nation's attention, especially the politicians' attention, that the drug availability is not uniform across the brands. I think this is the sad reality, but then we should understand and keep it in mind that it is important for therapeutic drug level monitoring. I'm not saying that one brand is superior, but we should understand that the drug concentration is variable across the brands. So irrespective of the brand we choose, we should monitor the drug levels. For steroids, that is not so. But at least when we choose antifungal as the treatment of choice, we should make it a point that we monitor the drug levels so that the optimal drug levels are reached and the patient will benefit better. So whatever it is 4 months duration, which is what is recommended. Now, the next question again to Dr. Gayathri Madam, others can pitch in, is once you start a therapy, how do we monitor? What frequency, what tests?
See, how frequently we monitor, I think we should do the monitoring at about 2 months time. Actually, you have the baseline investigations that see the IG level, the basic CT test you would have done. You've done the workup. I think you have to get the repeat of the chest X-ray to see the IG level at about 2 months time and see how they respond, to see whether there is any decrease in the serum IG level. Also assess the clinical response to therapy and how much the IG level has fallen towards this usual baseline which can come in as. So that's one of the things we have to do.
Yes, thank you so much, madam. So quickly, madam has rightly said 2 months, but it is, I think, 6 to 8 weeks. We should not start doing every week or every 2 weeks. The response is assessed every 6 to 8 weeks. Correct. The tests, again, when we monitor a person, there are 3 things we monitor: the clinical response. So that also now the new guidelines say use the Likert scores, that is the VAS scores. You ask the person what is the percentage of decrease. Clinical, radiological. For radiological, it is the chest X-ray. You obviously can't repeat CT scans. If you have an X-ray abnormality, you monitor. And immunological response. Dr. Abhishek, I think, has clearly said, or I think Dr. Gayathri Madam has said in the talk, that use only IgE level for monitoring the response. Correct? Do not do specific IgE. Do not use eosinophil counts. Though eosinophil counts may come down, it is the IgE level which will determine the response. Okay. So clinical, X-ray, IgE, total IgE. And very important point again, Gayathri Madam and Dr. Abhishek have already said, is identify the new baseline. If a person has 7,000, you don't tell the patient that don't expect it to come to 150 or 200. It might fall by 20%. Even a 20% fall is considered a significant fall. So the new baseline has to be obtained. I think that is about monitoring patients. Then there is also some questions on what if a person doesn't respond well or relapses fast. So steroid dependent ABPA. So this is something which is a common scenario. Steroid dependent or early relapses. So every time you taper steroids, there is a relapse. So what are the options for the clinician? This is for Dr. Mir Faisal. So what can a clinician do in such a case?
Yes, in cases where there are relapses again and the patient is on steroids and we are not able to taper the steroids, I think one antifungals, as we already discussed, we can start him on antifungals and try to taper the steroids. Then we have then we have the biologicals also, like we have anti-IgE therapy, we have the omalizumab, which can be tried. And now omalizumab has been used in ABPA, and in ABPAS we are using omalizumab. Then we have the newer biologicals like the benralizumab and the mepolizumab that are currently available. And if the patient is has asthma and his asthma is also not controlled, then we can try to use these biologicals also, so that we are able to taper down the steroids if the patient is not getting controlled.
Wonderful, sir. So I think thanks for bringing up the point of biologics. So I think for steroid dependent ABPA, one is try to combine and use. So that is approved. Now the thing which is coming up in a huge way is biologics. There is some data on long-term use of itraconazole and also nebulized amphotericin B. For lack of time, we can't discuss all these things, but biologics is one thing which would warrant some discussion. So, how many of the panel members have experience of biologics in ABPA? Wonderful. I think we can ask Dr. Mahavir quickly and Dr. Abhishek, which biologic would you choose? Omali, Mepoli, Benrali, all three are there in our country. Very quickly.
I have in ABPA I have always used omalizumab. First is the cost factor, and I've got wonderful response. I mean, many of the patients where I want to taper their steroids and plus the antifungals also, they are developing side effects also of these medications. So
how would you dose them, Mahavirji? The IG levels are sky high.
That's
how much dose would you give?
Normally, I tend to give 2 vials, and one patient I have given 3 vials every 15 days. But 2 vials every 15 days has been used in majority of my patients, and I don't go with the total IG or the patient's weight, because we are giving along with this another therapies, like it's a mixing and matching of all the therapies whichever is available. So normally 300 micrograms once every 2 weeks, and slowly even 1 vial once in 15 days. And unofficially even once a month also I'm using for these patients.
So I think there is data on omalizumab. In fact, that is the only biologic where you have a small RCT also.
Yeah.
But the problem is the dosing. Obviously, we'll have to underdose the person. Dr. Abhishek, quickly, we're running out of time. What biologic have you used? Dr. Abhishek is probably not hearing the question. So, Dr. Mir Faisal, sir, you also have used biologics in ABPA. As I would say that they're all off-label. The companies have not agreed, but the ISHAM guidelines have given a statement that in a case you can still use them. So you can use the ISHAM guidelines to justify using a biologic in a patient with ABPA.
We have used omalizumab as Dr. Mahavir sir was also saying. So we have used omalizumab, have been using it for a long time. But then yes, dosing is an issue, as you said. Dosing has always been an issue because of the high levels of IgE. Benrali and mepolizumab, I have some patients, but I have still not used. I'm just.
Sorry, I logged out.
Yeah, Dr. Abhishek.
Basically, the guidelines do not mention using it in first line, isn't it? That's the concern.
No, not in first.
I'm very clear. Please do not go home with the message that they should be used as the first line. They're used as the last resort.
Yeah.
Dependent ABPA or
I have a couple of patients who were on steroid dependent ABPAs, and we started them on mepolizumab actually. and we were able to wean off their steroids, and now they are on mepolizumab and high-dose inhaled corticosteroids, and the symptoms are well controlled.
Wonderful.
So this
Thank you
is
so
a
much,
very small
everybody.
data that I have.
Yes, I think I've used Omali, Mepoli, and Benrali in ABPA. All of them work extremely well. And see, the ABPA is a disease with very high eosinophil counts. So the anti-eosinophilics work wonders when you give ABPA, provided the patient can afford them. So all of them work very well. It depends upon what a patient can afford and what is available at your center. So it is 9:31. I know we have not brought up so many topics. There are a lot of questions coming. I'm very sorry for the audience. I think anybody can reach out to me or any of the panel members. We will be more than happy to clear the doubts. So the next 2 minutes, I will request all the panelists, all these experts on ABPA to give one take-home message to the audience. We'll start from Dr. Gayathri, madam.
See, I would like to emphasize that ABPA has to be kept in mind in asthmatics. It's not some kind of exotic disease. It still exists in India. You have to keep your eyes and ears open and do tests to identify it. Tests are available. And that's what I really need to emphasize, because I think sometimes ABPA becomes last on the differential diagnosis of why the patient is sick with an asthma exacerbation.
So what madam says is suspect. Then you will diagnose more ABPA. Thank you so much, madam. Dr. Mir Faisal.
I also want to emphasize on the fact that we have to suspect any asthmatic who coughs up sputum. I think we should try to screen if we are having. So it is we should screen and then move forward. I think we have to suspect.
Dr. Abhishek ji, your take on this.
I would want to say that no ABPA patient should go undiagnosed, because we have fantastic tests available, and it's also very important to note that not all ABPA patients warrant therapy. So that is also should be kept in mind. Asymptomatic and ABPA can be managed by a follow-up.
Thank you so much for that. That point we have not covered. Thanks for bringing it up. Asymptomatic ABPA can be monitored closely. Dr. Mahavir Modiji, your take-home message to the audience.
I think instead of doing total IgA as one of the first steps, what we are doing for years, I think we should convert whenever we feel that we are suspecting ABPA. Then in these patients, we should be doing aspergillus fumigator specific IgA as the screening test, and having value of more than 0.35. Then using this modified Isham criteria. And as Dr. Abhishek has said very well, that whenever we have aspergillus only sensitization and it is not caused ABPA, then these patients, they don't require glucocorticosteroids, they don't require antifungals. So ABPA-S or the other these terminologies like severe asthma associated with aspergillus, so those kind of terminologies, SAAF. So where we don't need glucocorticosteroids, we don't need antifungals. So ABPA, BM with bronchiectasis or with AM, these are the patients where we require all kinds of therapies, but not everybody with ABPA will require glucocorticosteroids.
Yes, wonderful messages. So though we screen and diagnose ABPA, we should treat only people who are symptomatic ABPA. That is what I think both the panelists have rightly said. Your take-home message for the audience, Dr. Nikhil sir. As a radiologist, what would you want the pulmonologist to know?
Before I'll talk about the take-home message, I would like to read Dr. Krishna's message, which he posted a long time ago. Congratulations, Team CCI and Team Zuventus. 938 logins, and that too on a India versus Afghanistan T20 World Cup match. Amazing moderation and acclaimed panelists.
Thank you so much. I think it is glad that 1,000 people have logged in to listen on ABPA. So I would like to again thank all the panelists for spending 1.5 hours of your precious time for educating all of us on ABPA. And I think with this, we should wind up the webinar, call it a day, and yet be available to all of them who have doubts to clear the doubts later on also. Thank you so much, everybody. Thank you, CC.
Thank you, Dr. Nagarjuna. Wonderful moderation, and you are the best.
Thank you so much.
Thank you. Of take-homes. Yes, thank you.
Thank you so much, Dr. Nagarjuna, for the moderation.
Thanks a lot, sir.
Thank you, everyone. Thank you all.